Yeah.
Yes. Yep.
Okay. So chapter 10 is the lymphatic system. We're going to talk about the lymph nodes of the head and neck, the cervical lymph nodes being in the neck. You're going to be able to define and pronounce all the key terms and anatomic terms, list and discuss the lymphatic system and its components, locate and identify the lymph nodes of the head and neck on a diagram and a patient, locate and identify the tonsils of the head and neck on a diagram and patient, identify the lymphatic drainage patterns for the head and neck, describe and discuss pathology of lymphoid tissue associated with the head and neck, correctly complete the review questions and activities for this lecture, and integrate an understanding of the head and neck lymphatic system into clinical dental practice. So right now you guys are about halfway there anyway. So when you do your extra oral exam, what you're feeling around are for lymph nodes. You're feeling around the neck, and you're feeling around the front of their ear area, and you're going down the side of the neck where the sternocleidomastoid muscle is and feeling around all of that. You go up around, you're feeling at the base of the skull in the kind of below the occipital region. And so you're feeling all around the patient for swollen lymph nodes. So now we are going to kind of just take it one step further and try to have an understanding of why we care if the lymph nodes are swollen. What does that mean when we find a swollen lymph node? So the lymphatic vessels are a system of channels that parallel the venous blood vessels, but there are more of them. And the tissue fluid drains from the surrounding region into the lymphatic vessels as lymph. So lymph is actually a fluid that drains into the lymphatic vessels. This is a picture of what they look like. Here's an arteriole or an artery, and then you've got your lymph tissue, all these little dots in there. This is your lymphatic vessel draining into that. And then here is a vein or venule. So they kind of are like sit right in the middle, the lymphatic tissue. Lymph nodes are bean-shaped bodies grouped in clusters along the connecting lymphatic vessels. Along the lymphatic vessels, they are positioned to filter toxic products from the lymph to prevent their entry into the vascular system. So they are a filtering system to clean out viruses, bacteria, toxic products of any kind, and they look sort of like a kidney bean shape. Lymphatic system, which is part of the immune system, includes the thymus and spleen. There can be superficial or deep, and they're not palpable unless they're in a diseased state. So if you are feeling a lymph node, when you're going around and you're doing your extra oral exam and you find a lymph node, that means that there's something going on. Now, does it mean that the diseased state is anything deadly? Of course not. It could be something as simple as you have some sinus drainage, or something as simple as you have a canker sore. So it doesn't have to be anything deadly or horrible for a lymph node to be palpable, but it definitely means that there's something that's causing it to be palpable. Otherwise, they shouldn't be. They are composed of organized lymphoid tissue and contain lymphocytes, or white blood cells of the immune system that actively remove the toxic products. So they have white blood cells in them. We've talked, you've talked in some of your classes, and we'll get more deeply into white blood cells when we get into perio and talk about periodontal infections and things like that. But they contain white blood cells, and those white blood cells are part of the immune system. So they're there to kill off any toxins that might enter your bloodstream. The lymph flows into the lymph node by way of afferent vessels. So this is a little bit different than the afferent thing we just talked about with nerves. So kind of put that aside and think of it with lymph nodes. So with lymph nodes, lymph flows into the lymph node by way of afferent vessels. So afferent brings the afferent vessels right here, bring the lymph into the lymph node. It almost looks like a hand kind of palming something with only 3 or 4 fingers instead of all 5. But think of it kind of like that. It's holding on to the lymph node. It's draining into it. Those are the afferent vessels. On one side of the node is a depression or hilus where the lymph flows out of the node by way of an efferent vessel. So you have several afferent vessels. You have one efferent vessel. And you can kind of see this dip right here is what they're calling the hilus. So it's kind of where the kidney bean dips in. And that's where your efferent vessel is going to come out. That's where the clean, filtered stuff is going to come through. So the dirty bacterial or toxic fluid comes into the lymph node from the top. It gets filtered through this process, and then the clean, filtered fluid comes back through this afferent vessel. The lymph from a particular tissue region drains into a primary node or regional node, and then the primary nodes drain into secondary nodes or central nodes. So oftentimes you'll hear patients, if somebody has cancer, for example, okay, they have these cancer cells, these toxic cells floating around in their body. And these toxic cells get into the lymphatic system. And so if you know anybody that's had cancer, particularly like breast cancer, for example, they will take lymph nodes out when they do the biopsy. And what they're doing is they're looking to see if those cancer cells are in the lymph nodes. And the reason they care about that is because the cancer cells then can, if not filtered out of the lymphatic system, can then continue to carry on through the bloodstream and infect or spread to other areas. So if they'll take out a primary node. If they don't find any cancer cells in the primary node, then they know the cancer has not had the opportunity to travel through the bloodstream yet. If they take out a primary node and they have cancer cells, a lot of times they will then take out a secondary node. Now, not all the time, but they'll take out a secondary node to see if the cancer is stopped there. And then they kind of have an idea of where did this cancer go? Like how much did it get to travel? In the outer tissue of the body, smaller lymphatic vessels containing lymph converge into larger lymphatic ducts, which empty into the venous system of the blood in the chest area. So there you go. This is where it dumps then into the venous system of the blood in the chest area. So if we have toxic cells floating around, we don't want them getting into the bloodstream. Drainage of the lymphatic ducts. The final drainage endpoint of the lymphatic vessels into the lymphatic ducts depends on which side of the body is involved. The lymphatic system on the right side of the head and neck converges by way of the right jugular trunk, joining the lymphatic system from the right arm and the thoracic to form the right lymphatic duct. So here's a picture down here that shows you the area on the right side of the body. So this person's looking at you. At the right side of the body that all drains into the lymphatic duct on the right. That lymphatic duct then will drain into the venous system at the junction of the right subclavian and right internal jugular veins. So here's the right jugular trunk. The lymphatic vessels on the left side of the head and neck converge into the left jugular trunk, actually a short vessel, and then into the thoracic duct, which joins the venous system at the junction of the left subclavian and left internal jugular veins. So when you are studying for this, I would suggest kind of drawing it like a tree. I did it on the PowerPoint for the arteries and veins, where I started out with a big kind of title on the top for the arteries and showed how they spread. And then on the veins, I went the other way and I showed how they converge back. And you might want to draw yourself a little picture like that to show which ones drain where. There are also a lot of videos on YouTube that you can watch, and you can certainly look up on KenHub and see what you can find there to watch. Whatever helps you to remember this, you may want to create your own mnemonic to kind of remember this. Superficial nodes of the head. What do we know about superficial? Where does superficial sit? Anybody?
Closer to the surface of
closer to the surface. So when you are doing your extraoral exam, you're feeling a lot of the superficial nodes of the head. So you're feeling around, and you feel around the base of the skull. Those are your occipital. Then your retroauricular, retro being back. Think of like retro music, goes back. Auricular, the auricle is the ear. So behind the ear are your retroauricular. Easy to remember, just break down the words. Anterior auricular, anterior would be in front of the auricle or in front of the ear. So right here, when you feel around, you're feeling the anterior auricular. Superficial parotid are superficial or on the surface of the parotid gland. They drain the surrounding area. And then you've got your facial. They run the length of the facial vein and they drain the area with the subgroups to them. And so these are the subgroups of the facial. I don't get that into the details on the questions. It's going to be more broad or basic. You will need to know these superficial node groups. And again, mnemonics, and draw yourself a little kind of a tree. It shows where they drain. So these drain into the deep cervical nodes, and these empty into the superior deep. So the deep cervical nodes are along the neck, and then the superior would be up higher at the superior part. This is a picture of the nodes and how they're kind of laid out. Now, lymph node locations are pretty much the same on all people, but they can vary in how well you can feel them. Think about the difference in the thickness of the tissue of the neck. If you've got somebody that's really large, you're going to have a harder time. They're going to have more tissue or more fatty padding around their neck versus somebody who's frail and elderly, where you can feel just like everything in their body. The deep nodes. These are nodes that we do not palpate. They sit too far in. So you've got your deep parotid and your retropharyngeal. So think of retropharyngeal, think of your pharynx and where it's located. Retro would be behind or deep to it. So your superficial cervical nodes. These are your superficial cervical nodes. Your superficial cervical nodes are kind of important because if you'll notice, this is where a lot of the stuff that we look at in the mouth drain. So for example, your submental are inferior to the chin. Think about when you're doing your extraoral exam, you're taking your fingers and you're rolling the tissue to the side to feel for swollen nodes. This tells you something. If you've got a swollen lymph node in the submental area and it's pretty big, and maybe the patient says, yeah, that hurts a little bit when you press on that. What does that tell you? So that tells you that there may be something going on in this area. So maybe their lower lip is going to get a fever blister or a cold sore. Maybe they have a canker sore on the floor of their mouth. Maybe they bit the tip of their tongue. Or more importantly, maybe their mandibular incisors are having a problem. So your submental cervical nodes drain those areas. So after the lymph drains into the cervix, the submental nodes then drain into the submandibular. So remember, submental is right up in the anterior part. Submandibular is going to be more back here. which we also feel. We take our fingers and we roll the nodes there too. So our submandibular is on the inferior or below the border of the ramus, superficial to the submandibular gland, and within the submandibular space. This drains the cheeks, the upper lip, the body of the tongue, the anterior part of the hard palate, and all the teeth except the mandibular incisors and maxillary third molars. So there's the important thing to remember. Star this, highlight this, write this down. Your submandibular lymph nodes drain all of your teeth except your mandibular incisors. So right down here, those drain into the submental, which ultimately go back to the submandibular, but their initial drainage is the submental. All of the rest of your teeth are going to come straight down. Think of it just draining like that, except your maxillary third molars. Think of how far back, they're the most distal tooth in your mouth. They bypass that and go right back, straight back to your cervicals. And then your submandibular also drain into your superior deep cervical nodes. So everything then is going to drain back. So think of it from that perspective. This area, your anterior region of your mouth, is going to drain into your submental. Everything else is going to come straight down to your submandibular. Your submental is going to flow back to the submandibular, and it's all eventually going to go into your deep cervical nodes, the superior or the top part. Except your third molars, maxillary third molars, are going to just go directly there. They're not going to come forward and drain to the submandibular and then go back. They're just going to drain directly back. So the best way for me is to remember, think about it when, like if your head was tipped back, everything is going to flow back. Does anybody have questions about that? Okay. So your deep cervical nodes, you have your superior deep cervicals. They are deep to the sternocleidomastoid muscle. They also drain the posterior nasal cavity. So think of where your sternocleidomastoid muscle is. And they're going to be deep. They're going to be on the inside. That's why you're not palpating them. They are way too deep in. You're just palpating superficial pretty much. They are going to be on the inside behind your sternocleidomastoid muscle. And so they also drain your nasal cavity. So think about how far back your nose goes. It's going to drain back there. Your posterior hard palate, your soft palate. So all the things that are back here. Basically things that are behind your submandibular, they're going to go back, straight back. So back this way. Is this making sense? Hopefully. So this next one, this is just an example of lymph nodes and how they work. So this would be a situation with a cancerous lesion, and it drains to the lymph nodes. So when they would do a biopsy, they would probably take out one of these nodes to see if the cancer has drained there. If the cancer has not drained there, then they know it's localized to this area. If it has, then they know it could be going even further, and they'll continue to check further. Here's a picture of your head and neck. So this is a good picture of how the lymph nodes drain. I'm going to show you a different one though. Let's talk about your tonsils first. Your tonsils are lymph tissue. They're made of lymphoid tissue. They also drain into the superior deep cervical nodes. And you have your palatine tonsils, which are on the arches of your throat. Those are the ones you typically think of when you think of tonsillectomy, getting your tonsils out. You have your lingual tonsils, which sit on the dorsal surface of your tongue at the very back. Your pharyngeal tonsils are also known as your adenoids, and they also are in that same area as your palatine tonsils. When children would get their tonsils out, many of you may have had your tonsils out. When they would take them out, they would normally take both of those out. They take out the palatine and the pharyngeal tonsils. So in other words, they would call it tonsillectomy and adenoidectomy. So they would take both of those out. And then you have your tubal tonsils, which are inside of your ears. We don't worry about those. So let's look at, these are some examples here of your lymph nodes and odontogenic infections. So if you have an infection in a tooth, if you have an infection on a mandibular anterior tooth, the infection is going to drain into the submental lymph nodes. The submental lymph nodes are then going to drain back to the submandibular lymph nodes, which are going to drain into the superficial, deep superior lymph nodes. So just kind of trace them back. By the time an infection gets back there, the patient's probably going to be having difficulties with their tooth already. But think about your teeth and where they drain. So the route of dental or odontogenic, so dental infections are called odontogenic infections. Traveling through the nodes varies according to the teeth involved. The submental nodes drain the mandibular incisors and the associated tissues. So right down here. And again, if you had let's say you had a lesion of some kind on your gum tissue down here, it would be the same thing. Then the submental nodes empty into the submandibular nodes or directly into the deep cervical nodes. And the submandibular nodes are the primary nodes for all of the teeth and associated tissues except the mandibular incisors, which we addressed up here, and the maxillary third molars. Then the submandibular nodes empty in the superior deep cervical nodes. That's really basically the whole path you just have to remember for lymph nodes. And this is just kind of a picture of how dental infection can spread. We have another chapter. The next chapter goes more in depth as to how dental infections can spread. Here's a picture of the lingual tonsil. Here's a case study. We're not going to do this. This I just threw in if you wanted to kind of look at that and see where it fits into the real world as far as what you're going to be studying. So you have a 6 millimeter vesicle on the hard palate near the maxillary anterior teeth, bilaterally enlarged tonsils near the throat. You have a cold and cough and are on cough medicine. So let's see, and this is the answer to this. So if you wanted to try and do this on your own and see if you can get it. If we have time at the end here after I do the next chapter, we can go back to this. But for now, I would like you to just at least look at this on your own when you're reviewing the slides. This is a picture, another picture of the way that lymph flows. And here's a picture when you're doing your extraoral exam of the different lymph nodes you're going to be feeling. So you start here and you feel the pre-auricular or anterior auricular. These are the same thing. They call them sometimes pre-auricular, meaning they're before, or anterior, meaning in front of. Either way, they're located in front of the ear or the auricle. Then you've got your posterior auricular. So you're going to take your fingers, and everybody do this while we're sitting here. Take your fingers and follow that path. You're going to feel your pre-auricular or anterior auricular. Then you're going to go around and you're going to feel your posterior auricular. And then we kind of drop down and we go around the base of the skull and we feel the occipital and have the patient tip their head forward so it tightens the tissue and you can feel for any lumps back there. And then you can come around and start with rolling the submental area over the jawbone. That's usually how you can more easily feel the lymph nodes, is they'll pop over the jaw. So you're going to feel your submental, and then you're going to go back and feel the submandibular. Which, by the way, when we used to do this in class, we used to do this actual extraoral exam on each other and talk about the different nodes. But for now, just kind of do them on yourself. Then you can feel the submandibular right there. Then you're going to go back up and feel the jugulo-digastric, which are going to be right below the ear. So right in the area of the jugular vein. And then your superficial cervical is going to be as you have the patient turn and you're starting to feel down the sternocleidomastoid muscle. You can feel that superficial cervical. You've got them on both sides, so you can feel down that for any nodes. And then you've got your posterior cervical, and you're going to feel down in that area. And your deep cervical chain, you're not going to actually be able to feel that much. And then you're going to end at your supraclavicular, so right above your clavicle, right here in the neck is where you're going to end. And that pattern's going to go pretty fast. And the more you do it, the faster you'll get with it. But that's basically the pattern right here of your extraoral exam. And that's what you're feeling for. So if you're going around and you're feeling on a patient and you feel a submandibular node, and it's on the right side, you're going to be kind of looking when you do your intraoral exam at what exactly is going on, if anything, on that right side. Does that make sense to everybody? That's not the one I wanted. So this is what it's going to look like when you go around.
I have a question.
Yes.
So on our PowerPoint, we have like extra pictures at the end, and two of the pictures point to different things and say like they're opposite of each other.
Is this the one you have?
No, I don't have that one on mine.
So what does it have that you're looking at?
Like this one says that it's pointing to the, I don't even know how to say it, jugulo-digastric. And then above it looks like it's pointing to the tonsillar. I don't know how to say it.
It's on the one on Canvas?
Yes, it's like it because we have 31 slides on ours.
Yeah, I think I took those two pictures out because they were confusing. This one has 31 too, but it must have different ones. Is this the picture?
I still see the PowerPoint.
Oh. Okay. Let me see if I've got it. How about this one? Can you see this one? Is this the picture you're talking about?
Oh no, it's the last one.
This one?
Yeah. On that picture, it's pointing to like the jugulo-digastric.
Mm-hmm.
And then if you go to slide 29, it says it's pointing to like the tonsil. Are those not pointing to the same thing?
They are pretty much the same thing.
Okay.
There's they're both like right here under the ear.
Okay.
I didn't highlight it on this one because it is different on this one. I think they're pretty much the same thing though.
Okay.
Okay. Any other question? Okay, so let's go to, so I have a lot of stuff on Canvas for that too. So just kind of draw out your own, if you want to help guide you, map kind of thing. If not, look at, I think there's a like a spreadsheet format where it has them narrowed in. Basically, again, the main things I just want you to know is the anterior mandibular area drains into the submental lymph nodes. The submental lymph nodes drain back to the submandibular nodes. The submandibular lymph nodes drain all the rest of your teeth except the anteriors, mandibular anteriors, and the maxillary third molars. Everything else, including the maxillary third molars, drains back into the superior deep cervical nodes. So everything kind of drains back. This next chapter is called Fascia and Spaces. This is a pretty short chapter. There's not a lot to know on this chapter. Fascia and spaces. Fascia's on top of layer of fibrous connective tissue. So fascia is connective tissue, lies deep to and connected to the skin that surround the much deeper muscles, bones, vessels, nerves, and organs. Fascial spaces are potential spaces between layers of fascia. So the fascia is the layer of fibrous connective tissue. The fascial spaces can be between the layers of tissue. I'm trying to get back in the meeting. Okay. The fascial spaces contain structures or parts of structures moving through the space. So this next slide shows you what it looks like. So if you look at this, here's the ear.
You're not on the PowerPoint.
We still have the old PowerPoint.
Oh, okay. Let me see. Let's get rid of this. That better? Is that the right one?
Yeah.
I think so.
Okay.
Oh, now we see Canvas.
I know. Get out of here, Canvas. Okay, let's get out of here. Try this again. Okay, how about now? Okay, so this picture, here's the ear, and this just shows you the layers of tissue. And within those layers of fascial tissue, between them are spaces. So they lay like sheets of paper with a little tiny space between them. And they surround all of these structures. They're what helps keep like your organs and stuff in place. So everything didn't just like fall all over. They take up, they fill in the missing areas, they keep it all connected together. That's the function of the fascia. It's connective tissue that holds things in place. It contains, it can contain some muscles, arteries, veins, bones, all kinds of stuff. If any of you have ever done yoga, they're really big in yoga about like draining your fascial space, keeping it healthy. Your connective tissues, they say if you keep that space lively and fresh, it will help all the nerves and blood vessels and arteries and muscles and bones that it surrounds. And so they're really big on those stretches that help drain the connective tissues and keep it healthy. You have superficial and deep. Your superficial are just deep to the attached skin. So you've got your attached skin, and then right underneath is your superficial. It separates your skin from the deeper structures. They vary in thickness in different parts of the body. They do not usually enclose muscles except the superficial fascia of the face and neck, which happens to be the part we care about. So the superficial fascia of the face encloses the muscles of facial expression, and the superficial cervical fascia of the neck contains the platysma muscle. So right down here. The blood vessels and nerves of the skin also travel in the superficial fascia. So your deep fascia are layers of deep fascia of the face and jaws, and they're divided into the temporal, mesenteric, parotid, and pterygoid. So think about what those are. Those are your muscles of mastication, your temporalis muscle, your masseter muscle, and your medial and lateral pterygoid muscles. Your deep cervical fascia layers are continuous with each other. So you have your investing fossa, which is your most external layer. It surrounds the neck and splits around the submandibular and parotid salivary glands and encloses the sternocleidomastoid and trapezius muscle. So your investing fossa encloses your sternocleidomastoid and trapezius muscle. And then you have your carotid sheath with visceral and buccopharyngeal fascia. It's deep to the investing fossa. So the investing fossa is more superficial. Deep comes the carotid sheath with the visceral and buccopharyngeal fascia. And that contains the internal carotid and common carotid arteries, the internal jugular vein. So if you think about this, your investing fascia contains your sternocleidomastoid and trapezius. They sit closer to the skin. Behind them, or deep to them, are your internal jugular, your common carotid, your internal jugular. All of that is more toward the midline. It's deep. Your visceral fossa contains your trachea, your esophagus, and your thyroid gland. And your buccopharyngeal fascia contains your buccinator muscle and superficial pharyngeal constrictor muscles. This name right here, buccopharyngeal, should give you an idea, buccinator, pharyngeal constrictor. It sounds just like what it does. And your vertebral fossa covers the spine and the vertebrae. So your vertebral sounds just like vertebrae. So think of vertebral vertebrae. Then you have something called your retropharyngeal space. So retro is going to be going back or behind. And then your pharyngeal space is behind your pharynx. So it's going to be kind of right in the back below your occipital area, kind of at like the base of the skull is where it's located. This is an important thing to us because it's called your danger space. So you'll see this probably on a quiz, maybe a test, maybe even boards. If it gets, it's considered your danger space because the spaces communicate with each other directly, along with the blood vessels and the lymph nodes. So the danger space, where its location has no specific contents apart from small, loose, fatty connective tissue, and is thus usually indistinguishable from the true retropharyngeal space on the imaging. The danger space is often subsumed into descriptions of a single retropharyngeal space or compartment. So it's a space. If it gets infection in it, it's considered to be very dangerous. So you've got your spaces of the face and jaws, your vestibular space of the maxilla, and your vestibular space of the mandible. So think about vestibules. Your vestibules are those little archways. Vestibular space of the maxilla, and then you've got a vestibular space of the mandible. And their relationship, maxillary, this relationship, mandibular posterior. The source of infection would be the maxillary molars for the vestibular space of the maxilla. The source of infection would be, so think about these spaces. These spaces are open areas, and so infection can get into them. So if you get infection in these spaces, it can be difficult to treat. Your canine space usually your maxillary canines. Your canine space is up here. So you have your canine fossa, your canine eminence, and your canine space, all that we need to know about. And then your buccal space, of course, is in your maxillary premolar region or mandibular molar region. It's in the cheek area. Your parotid space houses your parotid gland. And if you remember, your facial nerve passes in front of your parotid gland, or passes through your parotid gland. Your masticator space, it's a very general term for the entire mandible and muscles of mastication. When you're studying for the test, all the spaces kind of sound like their location. I'm not going to ask you real detailed questions about them. I will not ask you their exact location. So you will not need to know exactly where they're located. If we talk about any of the spaces, they're going to be the ones that sound like their name. I might ask you something about the canine space or the buccal space. I'm not going to ask you a very detailed question about where exactly is the buccal space located. So don't worry about memorizing all that. Just know the different spaces, have a general idea of what their source of infection might be. So right down here it says their source of infection. Their source of infection usually sounds kind of like what you would make common sense. Your canine space, the source of infection would be your maxillary canines. Your buccal space on your cheeks, their source of infection is going to be these teeth right here, these premolar areas. Some of them have more than one space that they can get infection. Your masticator, think of your muscles of mastication. Like, again, I'm not going to ask you exactly where is that space located. We don't need to know. The space of the body of the mandible, you can get an infection in there from any of your mandibular teeth. Your submental, the source of infection would be your mandibular posterior teeth and contralateral submandibular space. So that one's a little strange, but again, just kind of have a basic idea of where these spaces or what these spaces do. Do not spend a lot of time memorizing every location, trying to find every location. You can have spaces anywhere, pretty much where you have layers of tissue, connective tissue. They are all over your body. We only care about the spaces in the head and neck area, but you have spaces, fascial spaces all over your body. And again, when you're doing yoga, those are one of the things that they talk a lot about, is keeping that connective tissue healthy, because that connective tissue surrounds your nerves and your blood vessels. And if we keep that healthy, hopefully we're keeping our nerves and blood vessels healthy too. Does anybody have any questions on this?